Risk of Mortality in Pregnancy and Childbirthing for Infants and Mothers in the Black Community by Danny and Mary. The cultural group of focus is the Black community in the United States, specifically Black mothers and infants. Although maternal and infant health care has improved over time, Black women and infants continue to experience significantly higher rates of pregnancy-related complications, maternal mortality, and infant mortality compared with many other racial and ethnic groups. These disparities are especially concerning because they persist even when factors such as education, income, and insurance status are taken into consideration. This suggests that the problem cannot be explained solely by individual choices or socioeconomic circumstances, and that broader systemic and structural inequities play an important role. The crisis addressed in this project is the disproportionately high rate of maternal and infant mortality among Black mothers and infants. Black women are more likely to experience serious pregnancy-related complications and are significantly more likely to die from pregnancy-related causes than white women. Black infants also experience higher rates of infant mortality, preterm birth, and low birth weight. These outcomes can have long-term effects on families and communities and demonstrate that the issue extends beyond pregnancy itself. Several factors contribute to these disparities, including unequal access to high-quality healthcare, implicit and explicit bias amongst healthcare providers, systemic racism and social determinants of health, social and economic conditions such as housing instability, transportation barriers, employment, environmental conditions, and unequal access to resources can also influence pregnancy outcomes. In addition, differences in how patients' concerns are heard, evaluated, and treated within healthcare settings may contribute to poor outcomes for Black mothers. Understanding these factors is important because addressing maternal and infant mortality requires more than focusing on individual behavior. It requires examining the healthcare system, social conditions, and larger structures that influence healthcare outcomes for Black families. The quantitative literature consistently found that Black women experience maternal mortality rates that are 2 to 3 times higher than white women. Black infants also have significantly higher rates of infant mortality, preterm birth, and low birth weight. Importantly, these disparities remain even among women with college degrees, full-time employment, and health insurance, indicating that socioeconomic status alone does not explain these differences. The research identifies systemic racism, healthcare bias, delayed treatment, and unequal access to quality prenatal care as major contributors to these disparities. Overall, the literature demonstrates that Black maternal and infant mortality is a widespread public health issue driven by structural inequities rather than individual behaviors.
Two professionals were interviewed to gain perspectives on Black maternal and infant mortality from both healthcare and community settings. The first interview was with Leah Lawson, LMSW, an outpatient medical social worker with Rochester Regional Health, who works with pregnant women and families receiving prenatal and postpartum care. The second interview was with Sulaimana Burns, CEO of Support Black Business 607 and the Black Doula Network, who works to improve maternal health outcomes by increasing access to Black doulas and culturally responsive birth support. These interviews were conducted to better understand the barriers Black mothers face and identify community-based solutions. Both interviews emphasized that Black maternal mortality is influenced by systemic racism, healthcare inequities, and social determinants of health. Lawson discussed how implicit bias, limited provider diversity, transportation barriers, housing instability, and financial challenges affect maternal health outcomes. Burns focused on the importance of culturally responsive care and explained how Black doulas help advocate for patients, reduce stress, and improve communication between mothers and healthcare providers. Both interviewees stressed that stronger partnerships between healthcare systems and community organizations are essential for improving maternal health outcomes. The primary points for both interviews were that Black women are often not heard or believed when seeking medical care, implicit bias affects healthcare decision-making, and there is a need for greater diversity among healthcare providers. Lawson emphasized the importance of addressing social determinants of health alongside medical care, while Burns highlighted the role of doulas in providing culturally responsive support and advocacy. Both agreed that increasing cultural competence, improving provider education, and expanding community-based resources are necessary to reduce maternal and infant mortality disparities. The findings from both the quantitative research and qualitative interviews shows that Black maternal mortality is influenced by systemic inequities rather than individual choices or behaviors. Rosenblum and Travis explain that race is socially constructed and that differences between groups often result in unequal access to resources and opportunities. This framework helps explain why many Black women experience poorer maternal health outcomes despite having education, stable employment, and health insurance. The interviews with Leah Lawson and Suleimana Burns supported these findings by identifying implicit bias, lack of provider diversity, and inadequate multicultural education as barriers to quality care. McNamee argues that success is not determined solely by hard work or personal effort. The findings in this project reflect this idea because many Black women still experience discrimination and poor maternal health outcomes despite achieving educational and financial stability. These results demonstrate that systemic barriers continue to affect maternal health care regardless of individual achievement. The culture-centered counseling model, described by Corey et al., also helped explain the findings. The model emphasizes multicultural awareness, understanding the historical and cultural experiences of clients, and applying culturally responsive skills in practice. The interviews demonstrated that healthcare providers who recognize their own biases, understand the historical experiences of Black women, and collaborate with community organizations can build trust and improve maternal health outcomes. Overall, these frameworks show that reducing Black maternal and infant mortality requires continued advocacy, cultural responsive healthcare, provider education, and systemic change rather than relying solely on individual effort. Intervention strategy should focus on addressing both the medical and social factors contributing to Black maternal mortality. One important strategy is improving access to high-quality, culturally responsive prenatal, maternal, and postpartum care. This includes increasing access to doulas, midwives, community health workers, and other providers who can build trust with Black women and provide continuous support throughout pregnancy and postpartum. Healthcare organizations should also strengthen implicit bias and cultural humility training for providers. Improve screening and treatment for conditions such as hypertension and cardiovascular disease, and establish standardized protocols for recognizing and responding to maternal warning signs. These interventions can help reduce preventable complications while also addressing the communication and trust issues that many Black patients experience within the healthcare system. Researchers and experts also recommend addressing the broader social determinants of health that influence maternal outcomes, including access to healthcare, transportation, housing, nutrition, employment, and economic stability. Expanding Medicaid coverage and postpartum care, particularly beyond the immediate weeks following delivery, can help women receive treatment for complications that may develop after childbirth. Hospitals and healthcare systems should also collect and examine maternal health data by race and ethnicity to identify disparities and hold organizations accountable for improving outcomes. Additional research is needed to better understand how racism, socioeconomic inequality, geographic differences, and health care access interact to affect Black maternal health. The most effective approach is likely to combine healthcare reform with community-based interventions and policy changes. While programs such as doula support, improved prenatal care, and maternal health initiatives have shown promise, persistent racial disparities demonstrate that these efforts must be expanded and sustained. Future interventions should prioritize the voices and experiences of Black women themselves, increase the accountability within healthcare institutions, and focus on prevention rather than responding only after a medical emergency occurs. Addressing the crisis requires a long-term, comprehensive approach that recognizes Black maternal mortality as both a healthcare issue and a broader social and systemic problem.